Hi, do you have any concerns about your baby today? Yes, she spits up a lot. Should I switch her formula? Raise your hand if you've ever heard this concern from parents of an infant. These poor parents are covered in vomit, have bags under their eyes, and are looking to you in desperation. I'm Colleen Sloan, a pediatric PA and registered dietitian, and this is the Exam Room Nutrition Podcast, where each week I give you answers to common nutrition questions to help you become a more confident, compassionate clinician. Now, I have parents like this at least once a day. So for today's episode, we'll discuss infant reflux and how you can reassure nervous parents and also provide them some relief. Make sure you stick around to the end for my nutrition notes section because I'll be reminding you of some red flag symptoms and can't miss diagnoses that can mimic reflux. Reflux, or GER, is extremely common and occurs in roughly 40 to 70% of healthy infants. It peaks at about 4 months of age, and the frequency decreases with the increasing age, and usually self-resolves by age 1. It is a major cause of parental worry and anxiety, and really, these nervous parents just want to know that their baby is okay. So get comfy and join me in welcoming registered dietitian and fellow Floridian, Kristen Gooch, to the show. Kristen is a registered dietitian, certified lactation counselor, and board certified in pediatric nutrition. She has worked in pediatric nutrition for the past 8 years and started an online practice called Happy Tummy Nutrition this year. You can follow her on Instagram at Happy Tummy Nutrition. Kristen, I can't wait for this topic. Welcome to the show.
Hi, Colleen. Thank you so much for having me.
I can't wait to get into this topic because parents ask me this question literally multiple times a day about their babies and that their baby is spitting up, and it causes so much parental concern. So I'm really excited to learn some different strategies that we can use with nutrition and formula and different feeding strategies to help give these parents and babies some relief. But I would love for you to give us an overview of some of the signs of reflux. What are we looking for?
Yeah, so that's a great place to start because we know reflux shows up in so many different shapes and sizes. So it certainly can be difficult to tell what is normal and what causes concern. First off, if it seems to be more than normal or if the baby seems uncomfortable after feedings, that could be a red flag. Another sign is that excessive crying or fussiness, especially during or after those feeds. So it's it's like they're trying to tell us something hey, something's not quite right here. You might also notice that your baby is arching their back or squirming a lot during feedings, and then especially when lying down. And then we also see some trouble sleeping at night for babies with severe reflux, and that's just due to the discomfort, and also poor weight gain might be a sign of concern.
Are there specific questions that can help the clinician kind of guide their decision-making, whether this is true, gastroesophageal reflux disease, or if it's just kind of like a happy spitter? What specific questions can the clinician use to tease those differences out?
That's a great question. There's so many causes of reflux, and some are more concerning than others. So I think it's important to explain to the parents that babies are born with an immature digestive system. And that's why reflux occurs, just because that lower esophageal sphincter, it's not fully developed yet. We also see a lot of reflux with overfeeding. So that could be another place of education when the baby consumes too much milk in a single feeding. Of course, that excess volume can put pressure on the stomach and again, cause the contents to come back up. Another concern is food allergies or sensitivities. So that could be another probing question of, if the baby's formula fed or breastfeeding, certain foods in the mom's diet may trigger those reflux symptoms. And then also in formula-fed babies, they may be sensitive to specific ingredients, such as the cow's milk protein. And then the clinician could be asking some of these more in-depth questions or, doing their exams, the structural or anatomical issues, such as pyloric stenosis or a hiatal hernia, which we would see a lot of reflux with those conditions. And again, those often require further investigation and specialized treatment plans.
Yeah, I think those are really important things for clinicians to think about. And my clinicians who are listening will know this. Specifically, it's very important that you do not miss pyloric stenosis. And I usually explain the difference between a happy spitter and a baby who's got pyloric stenosis. That baby with pyloric stenosis is going to be literally projectile vomiting. And I will sometimes describe it as If the baby is sitting across the room from mom or dad, would that vomit hit them in the face? Like apocalyptic spit up. Because often parents will say, oh, well, yeah, when I'm burping her over my shoulder, the spit up kind of hits the floor and it flies across the room. And it's really important that clinicians differentiate between the two, because not all spit up is pyloric stenosis, but sometimes it is. And that's really important to rule that out. Now, you had mentioned a few things, and I would love, as the dietitian, I would love to hear what questions you ask clients about the baby's feeding. Because as a clinician, it's kind of easy to just, what formula does the baby drink? And is she satisfied? Does she drink enough? And then be done with it. But what are those specific questions to really determine if there is overfeeding or any other issues with that?
So I ask parents to kind of walk me through their day, like what time the baby is up, what time they're feeding, how long the feeding is. Are they latching on the breast? Are they feeding from both breasts? What kind of bottle they're using? How long it takes for the baby to finish a bottle? I ask them if they are, burping their babies, taking breaks. I'm asking them if they have like a set schedule or if they're feeding on demand. I often encourage more of that on demand feeding. So that way it leads to less of that overfeeding, less of that baby getting hangry. So really focusing in and educating parents on those hunger and fullness cues. I'll ask more about like the stooling patterns and also doing a growth assessment as well. So that's something that would raise a concern if baby's not growing or meeting those growth milestones. That might be a concern that they're not getting enough milk. And also we can check for dirty diapers and wet diapers. We want to make sure that they are having an appropriate number of those.
I think that's really helpful to kind of hear how a dietitian asks those questions, because clinicians are the ones who need to be doing that in order to know if we need to refer out to a dietitian for more assistance. We'll get back to the episode in just a minute, but I wanted to invite you to an exclusive social hour. I'm calling it the Clinician Dietitian Mixer. This will be hosted virtually and it is by invitation only. However, if you are a registered dietitian, medical doctor, physician assistant, or nurse practitioner, you are invited. As dietitians, it's sometimes hard to find referring providers and patients to work with. And as clinicians, it's hard to find dietitians who can work with your patient. So I wanted us to join together so we can network and collaborate in a really fun, informal way. So if you are interested in joining us, this will be held virtually on May 29th at 7:30 p.m. Eastern Time. Registration is required to maintain the integrity of this event, but if you are interested in joining us or if you have any questions about this, there is a link in the show notes. Please go ahead and fill out that interest form. And I can't wait to meet you, and I hope you can make it. All right, let's get back to the episode. So if we as the clinician have determined that this is not pyloric stenosis, it's more just physiological, which just means that the baby likely will grow out of it, how can we reassure nervous parents that this reflux is normal, really without minimizing their concerns? Because this happens to me all the time. I will go through an education and tell them that this is normal, but they're still really, really worried about it. So what specific words and language can we use to help these parents navigate this?
Yeah, so it's so important to validate the parents' concerns. We want to begin by acknowledging that it's normal for parents to feel anxious about their baby's growth and their baby's health, and just reassure them that we understand their concerns and we're here to support them, like through this journey, through this feeding journey. It's important to inform parents that reflux, like we said, it's common. It affects up to 50%. I've actually seen a bit more than that, like research, but 60 to 70% of babies in the first few months that do experience reflux, and emphasize that most cases, it's not a serious medical condition. However, there are some practical strategies that we can do to help manage the reflux while they are going through it.
Yeah, I would love to get into those, because I think that's what the listeners are really looking forward to, is hearing, okay, I told them it's normal. Now, what do I do about it? Do I just send them off and say it's normal, just deal with it? Because the parents are coming to us looking for those solutions and to alleviate this problem. So what are some of those strategies to help relieve the baby's reflux?
Yeah, that's a great question. A lot of parents are wanting that quick fix, but we often try to veer them away from that and just focus on some natural strategies to start with. But I typically start with positioning. It's an easy and effective strategy, and the goal is to keep that baby upright during and after feedings. So, the mom can hold the baby against her chest or keep the baby in a carrier just to keep them at that 45-degree angle. And we typically want to do this for 20 to 30 minutes after a feeding. And then another strategy that I'm a huge proponent for is on-demand feedings. And this works with both breastfeeding and formula feeding babies. So like I said, rather than having a strict schedule for feeding times, we want to allow the baby to eat when they are showing those hunger cues and then stopping the feed once they're satisfied. And this does help with providing smaller, more frequent feeds, which is another strategy that can help with reflux. And then I also like to tell parents to slow down the feed. So it may help to burp their baby after every 1 to 2 ounces, or if breastfeeding every 5 to 10 minutes, if possible. And it just helps release air from the stomach for a much smoother digestion process. And again, less likelihood for that reflux to occur. If none of those work, then, it might be time to look into some other options, such as, formula changes or thickening agents, or again, investigating mom's diet. And then another potential lower risk thing that we could try is probiotics. There are certain strains of probiotics that are shown to help protect against reflux. But all of these should be done under medical supervision. We don't want moms to just go, trying these different things willy-nilly.
I'm glad you mentioned the formulas because so many times parents will come and be like, oh, we tried this formula for a day and then we tried this formula the next time and she's still spitting up. And so I would love if you could discuss when should formula be changed and then how long should we give that formula a try before switching it to a different one?
Some reasons that would warrant a formula change would be if a baby is exhibiting signs of a food allergy or intolerance to a specific ingredient. Some of these symptoms include persistent reflux or blood in the stools, severe eczema, and poor weight gain, which could all be a sign of an allergy or intolerance. If a baby is experiencing persistent digestive problems, again, like constipation, diarrhea, or excessive gas, we may want to change the formula then to help alleviate those symptoms. And that's when we might want to switch to a partially hydrolyzed formula or extensively hydrolyzed formula, which just eases the digestion. So the baby's not having to break down those nutrients. Abrupt formula changes can sometimes lead to more digestive upset and other issues. And then I recommend to give 2 to 4 weeks for that adaptation before we go and switch to another new formula.
So I know that there are specific formulas specifically made for babies with reflux. The big ones in America, Enfamil AR and Similac for spit up, they both usually have an added rice starch that makes it a little bit thicker for the baby. So those are already pre-made formulas specifically for reflux. Now, I do know some parents and even some clinicians are asking about thickening the formula themselves with like a rice starch or an oatmeal cereal. But I always suggest to my colleagues, if you are wanting to use, a thicker formula because of spit up, I usually just suggest going with the specified formulas for reflux rather than trying to teach your patients how to thicken the formula because it can get a little bit tricky and not every family is reliable in doing this properly and safely. There's not really hard and fast guidelines. Now, of course, if it's a swallowing concern or aspiration, of course, that's when you need to refer out to a speech language pathologist to assess for that. And then they can give those proper thickening guidelines. But in general, when it is just for reflux, I always suggest using one of those specified formulas for spit up that are already thickened a little bit, just to make it easier for the family. All right, let's move on to medical management of reflux. And I'm curious as to your thoughts on whether PPIs should be utilized in every baby with reflux.
There's definitely some controversy on the topic as well. We know that PPIs are a class of drug that works by reducing the amount of stomach acid. And the stomach acid is actually a very important component of digestion. It's made up of digestive enzymes that are needed to break down and absorb nutrients. So reducing that component can sometimes slow down the digestion. And that's why we see sometimes like that curdled milk or vomiting with the infants. It's important to distinguish between if it's, physiologic reflux, because that's generally harmless in infants. For considering PPIs, we want to address natural strategies first. So positioning, feeding modifications, and lifestyle adjustments first. Many babies respond to that, and then they don't need that medication. We also want to, discuss the risks and the side effects of PPIs. In infants, prolonged PPI use has been associated with an increased risk of infections. There are also concerns about long-term effects of the acid suppression on the developing digestive system. So the decision to use PPI should be carefully weighed against the benefits of it. And if we have a goal for potentially weaning off of it, we'd want that in place. We have been seeing some overuse and misuse of PPIs in infants with reflux. We've seen them being prescribed inappropriately without a clear indication or adequate diagnostic workup. And then again, without a plan to wean off of it. And sometimes these kids get put on PPIs for years without having any plan of coming off of it.
And actually, ranitidine was recalled in 2019. So a lot of pediatric providers aren't really prescribing them at all. That medication was recalled for concern for an impurity that is like a possible carcinogen called NDMA. And so a lot of us really are pulling back from using PPIs altogether, unless it's severe cases of, malnutrition and the baby has some failure to thrive. And a lot of parents ask about starting on a medication because they just want a solution so badly. And they've heard about some different medications that maybe help their friend or their neighbor or whatnot. And I always try to explain to parents that using a medicine like a PPI will not actually stop the baby's reflux. It only lowers the amount of acid that's in their stomach. So we could be not really giving them a solution at all and potentially giving them a medication that can cause some side effects or some harm later on in life. So I always try to educate them that it's not going to resolve the baby's amount and volume of spit up. It just decreases the acid that's in their stomach. So it might not be a viable solution. So I think that's a really important thing that providers really educate themselves on and know exactly why and who they should prescribe a PPI for. Now, other things that parents ask me about all the time are the natural treatments like colic drops and stuff that's on the shelves. So I'm curious as to what your thoughts are with that and if they actually help or if they just help the parent feel like they're doing something.
Yeah. So they can certainly be explored. They're over-the-counter low-risk options. As far as colic drops or gripe water, there's not a whole lot of evidence to back those up in helping prevent reflux. I typically don't recommend those. It's not like my first line of treatment, though they are recognized as safe. There's just not a whole lot of evidence behind that. I do like to focus more on like the diet and lifestyle, and especially for breastfeeding mothers, making those dietary modifications. If we do need to eliminate dairy or other foods, that's definitely something I do consider, but only if there's a suspected food sensitivity or allergy.
This has been so helpful because like I said in the beginning, this is such a common question. I get asked this multiple times a day. And I would love to finish out with something that you actually talk about a lot on your Instagram page. And it's why clinicians should stop saying that your baby will just grow out of reflux. It's fine. And I'm curious as to why you don't like that saying and what else should they say instead?
Yeah, so that's such an important point to address. And it's true that babies do eventually outgrow the reflux as their digestive system does mature. However, telling parents simply that your baby will just outgrow reflux, it's often dismissive and unhelpful and kind of makes the parents feel like they're not doing a good job. So instead of making this blanket statement, we can explain the natural progression of reflux, share that symptoms do improve with development, but also addressing those current symptoms and discomfort. We want to focus on some of those practical strategies first to manage reflux, like we said, such as positioning, feeding adjustments, lifestyle changes. These are some actual tips that we can give the parents like within that clinical setting. If they're wanting to dig a little deeper, I do highly recommend working with a dietitian or a practitioner that is, heavily focused on infant nutrition and digestion.
Yep. I love that. I love that we ended there, that it is a collaborative team approach, that if you as a clinician are just struggling or your parents just need a little bit more handholding than you can provide in that clinic visit, refer out to a registered dietitian, just like Kristen, because they have the time, they have the education, and they have the ability to help parents kind of walk through this season of life. So Kristen, I would love if you wanted to share where people can find you on social media and where they can get more information about you and what you do.
Yeah, so I am on Instagram at Happy Tummy Nutrition. You can also visit my website at happytummynutrition.com.
Awesome. Thank you so much for being here. This has been so helpful for me and for my clinicians listening. So I just appreciate you spending the time with me. Thanks again, Kristen, for being here.
Yeah, thanks so much for having me.
All right, now it's time for my nutrition notes. While it's tempting to just tell the family that their baby is a happy spitter, I want to remind you of a few red flags that should alert you to an alternate diagnosis. Before you just go and suggest to thicken feeds or change the formula, be sure you do a thorough physical exam and check the baby's growth. So here are a few reminders of can't miss diagnoses and their associated symptoms. First of all, if you have a baby older than 6 months, just now presenting with symptoms, or symptoms are increasing or are persistent after age 12 months, consider an alternative diagnosis. You might be dealing with a gastrointestinal obstruction, such as pyloric stenosis. Remember, this is when the baby has persistent, forceful vomiting and is less than 2 months old. Now, bilious vomiting suggests causes of intestinal obstruction, such as Hirschsprung's disease, intestinal atresia, midgut volvulus, or intussusception. Other gastrointestinal disorders that you should consider include gastric motility disorders like achalasia or gastroparesis, and food allergy or intolerances such as cow's milk protein allergy. Some neurological symptoms and signs that you need to be aware of include a bulging fontanelle, rapidly increasing head circumference, seizures, nocturnal vomiting, macrocephaly, and microcephaly. Also, things like meningitis, a brain tumor, abuse, or hydrocephalus can suggest causes of increased intracranial pressure. Now, while this list isn't exhaustive, hopefully it was a reminder for you to always perform a thorough history and exam and be looking at the baby's growth chart, including their head circumference measurements. You might save a baby's life. And thanks so much for joining me today. I hope this conversation was helpful for you. I've got a fun new feature for you that's available in the show notes. All you have to do is click the button that says send Colleen a text message, and you can send me a direct text message from your phone for any questions that you have or any topics that you would like me to feature on a next podcast episode. Thanks again for choosing to listen to the Exam Room Nutrition Podcast. That's it for today. And as always, let's continue to make our patients healthy, one exam room at a time. I'll see you next time.